Hello, my name is Chris Solomon. I am a specialist hemato-oncology pharmacist. I work at the Royal Marsden, and I'm here to talk to you a little bit about high-dose methotrexate. This is a 35-minute lecture or so. I do apologise, and I don't apologise at the same time, that this is a very wordy lecture, but I do intend this lecture to be used as a guide for anyone who is involved in patients who are receiving high-dose methotrexate. As a reference guide, so all of the slides within this presentation are very wordy, but could be maybe a resource if somebody's sort of involved in the care of a patient receiving high-dose methotrexate. So the lecture overview, what I'm going to talk about in this lecture, I'm going to talk about the indications for high-dose methotrexate, so particularly which diseases we use high-dose methotrexate for. I'm going to talk about the pharmacology of high-dose methotrexate, well, methotrexate in general, but particularly in high-dose methotrexate. And that's not just an academic consideration. It actually does. Once you understand the pharmacology of high-dose methotrexate, it does go some way to understand some of the complexities that are encountered with patients receiving treatment with HD-MTX. I'm going to talk about the pharmacokinetics, which are quite unique, and it's really fundamental to the safe delivery of high-dose methotrexate to patients. If we understand the kinetics of methotrexate, particularly at high doses, then we can safely deliver this regime and minimize toxicities. And that brings us on nicely to the next topic, which is toxicities. I will go through the long list of toxicities which our patients encounter when they're receiving high-dose methotrexate. I'm going to talk about the supportive care, which is critical and mandatory in the safe delivery of this regime. So I'm going to talk about phenolic acid rescue, urine alkalization, and hyperhydration. And I'm going to talk about glucarpidase, which is a high-cost drug which has some interesting properties, but we'll talk about that right at the end of the presentation. Thank you. So, the indications for high-dose methotrexate. High-dose methotrexate is most commonly used in acute lymphoblastic leukemia, where it really is a cornerstone of the treatment of ALL, and really where methotrexate in the higher doses was trialed. And most of the experience that I've got and the most experienced clinicians with this regime are clinicians who are involved in the care of ALL, and they tend to be the pediatric regime, as ALL is primarily a disease of younger people. High-risk lymphomas will also receive high-dose consolidation with high-dose methotrexate. Burkitt's lymphoma, where methotrexate really is a cornerstone of the treatment regime for this type of very aggressive lymphoma. Primary CNS lymphoma, we also is an indication for treatment with not necessarily as a part of a combination treatment in primary CNS lymphoma. Very high doses. High-dose methotrexate is also used in osteosarcoma, so doses that are extremely high in comparison to the other indications listed here. And patients who are suffering from leptomeningeal diseases, where intrathecal methotrexate doesn't obtain high enough intracellular concentrations, so we do have to use high-dose methotrexate to obtain adequate concentrations intracellularly in this patient group. So, what is high-dose methotrexate? High-dose methotrexate is essentially defined as any dose that is greater than 500 milligrams per meter squared. Intermediate dose methotrexate is defined as any dose really between 500 to 50 to 500. Low dose is defined as less than 50 milligrams per meter squared. Conceptually, I think that any dose that requires rescue, phenolic acid rescue, is high dose methotrexate. This lecture will talk about patients who are all receiving doses that are greater than 500 milligrams per meter squared. The only regime that I'm particularly aware of is a part of one of our pediatric acute leukemia protocols, ALL 2011, where they have a part of that regime where they increase doses of methotrexate, incremental increases in dose of methotrexate, when sometimes they can approach the 500 milligram mark. Low dose methotrexate is also again used in leukemias as part of maintenance therapies, but it's also encountered for other diseases where methotrexate is used as a DMARD, particularly in autoimmune conditions such as rheumatoid arthritis, which is given often as a weekly regime orally. And again, oral weekly methotrexate or intrathecal methotrexate is often tolerated without necessary. It's not without the requirement of phenolic acid rescue. So how does methotrexate work? So the mechanism of action of methotrexate, which most people are relatively aware of, is the inhibition of the dihydrofolate reductase enzyme. This prevents the catalytic conversion of oxidized folates to reduced folates, i.e., the production of tetrahydrofolate from dihydrofolate. By this mechanism, it prevents the production of thymidylate and the purines. Methotrexate itself is an analog, really, of a folate. Here you can sort of see phenolic acid, which is an oxidized folate, sorry. And the structural similarities between this folate and methotrexate is pretty clear to see, just the substitution of a methyl group here and an amine group. But these subtle differences result in a substantially increased affinity to the dihydrofolate reductase enzyme, meaning that methotrexate has about 1,000 times the affinity for dihydrofolate reductase than a reduced folate. As you can see here, this is the primary target for methotrexate, the dihydrofolate reductase enzyme. And what this enzyme does conceptually here is nice little schematic. It's pinched from, I think, from up to date, from a oxidized folate to a reduced folate, which continues on into being a coenzyme in purine and pyrimidine synthesis. So inhibition of methotrexate stops DNA production by the prevention of nucleic acids, nucleotide bases, sorry. Meaning that methotrexate is active in the S phase of mitosis. But as you can see from this image, methotrexate does have several other targets, including thymidine synthetase inhibition, which is actually the target for 5-fluorouracil and capecitabine, and voltrexate for that matter. By inhibiting this enzyme, pyrimidine synthesis is inhibited, and therefore this is why methotrexate inhibits the production of both purine and pyrimidine synthesis, as you can see here. The last mechanism of action of methotrexate is the inhibition of Kraft and Ali-Kraft enzymes, which are involved in the reductions of folate N10 methyl tetrahydrofolate and the synthesis of adenine and guanosine. Interestingly, inhibition of this enzyme sort of by proxy results in a build-up of some of the precursors of purines, and the build-up of these sort of pre-purine compounds have relatively potent anti-inflammatory effects, and it's likely that weekly low-dose methotrexate inhibition of these enzymes, it is likely that this results in the anti-inflammatory DMARD effect of low-dose weekly methotrexate. So overall, methotrexate mechanism of action is a sudden depletion of reduced folates. This essentially interrupts DNA synthesis and results in cell death. It's not quite as simple as just malignant cells, which are more frequently are in the S phase of DNA synthesis, of mitosis, are more vulnerable to methotrexate. There's a couple of other things that are going on, including a process known as polyglutamation, which occurs in intracellularly only when higher intracellular concentrations of methotrexate are achieved. So when intracellularly a dose of 2 micromoles per liter are achieved in the cell lines which are largely the indications for high-dose methotrexate, ALL, Burkitt's, etc., etc. Polyglutamation occurs. Now, polyglutamation is quite important in the fact that the polyglutamated methotrexate has a higher affinity for all of the targets for methotrexate, but has a particularly higher affinity for dihydrofolate reductase. Interestingly, the malignancies which don't polyglutamate methotrexate at high doses tend to be refractory to treatment with high-dose methotrexate. So if ever you're asked why AML isn't treated with high-dose methotrexate, it's because AML, that cell line doesn't polyglutamate methotrexate at higher concentrations. Polyglutamation also may go to some way to explain why some patients who may experience prolonged toxicities with a delayed excretion time because of the higher affinity for all of the targets of methotrexate when it's in a polyglutamated form. And that brings us on nicely to methotrexate toxicities. The main toxicity of methotrexate is acute kidney injury. Methotrexate tends to crystallize out into renal tubulars, and the crystallized form of methotrexate is extremely toxic and results in epithelial toxicity. I mean, it's epithelial necrosis, not toxicity. As methotrexate is a weak acid, therefore methotrexate crystals do not appear when in the urine, but the first indication of crystallization would be an increase in creatinine. So it's vital that we keep a very close eye on the creatinine and creatinine clearance of all patients who are receiving high-dose methotrexate. The AKI occurs up to about 12% of patients. Actually, the figures are about 3% of all ALL patients, so acute lymphomastic leukemia patients, and 9 to 12% of all lymphoma patients. I couldn't find a reason why, but I suspect because organ function is going to be a little bit better in the younger patient population of ALL patients, whereas in lymphoma tends to be a bit of a larger umbrella group of patients. They can be young or old. 90% of methotrexate is excreted renally. Therefore, the AKI essentially prolongs exposure to the toxic effect of methotrexate, which is precisely the opposite of what we're trying to achieve. The delayed clearance further propagates the exposure to the patient to the drug. The other 10% of methotrexate is excreted hepatically, and it's probably not an important mechanism of excretion. Risk factors for AKI include renal dysfunction. That's why the workup for selecting the appropriate dose for a patient is important. The pre-assessment of patients to ensure that their renal function or renal dysfunctions are identified and managed appropriately. Volume depletion. This is quite a nauseating regime. So patients who are suffering from vomiting, this needs to be controlled by appropriate use of antiemetics. Is also because it is being quite a GI toxic regime as well, may result in significant diarrhea. So we need to keep an eye on that patients aren't volume depleted. Acidic urine. So methotrexate is a salt of a weak acid, and weak acids act as weak acid IR in an ionized form in more basic conditions. So we need to make sure that patients' pH are above 7, so that the solubility of the methotrexate is much greater, and it's not in the crystallized form where it is in more acidic conditions. And of course, pharmacists' favorite, drug interactions. So I just wanted to go through some of the risk factors individually and talk about patient assessment. So because of the mandatory nature of the supportive therapy, it is imperative that patients have central access. Although none of the drugs are here, or most of the drugs here, or all of the drugs here really could be administered via a cannula, it's the importance of guaranteeing that administration that really is critical here. So it is very important we have central access, so we guarantee that we can get the appropriate phenolic acid rescue, hyperhydration, alkalization into a patient. So it's mandatory that patients have central access. We have plenty of time to identify patients with impaired renal function. So we would expect, certainly before cycle 1, a renal assessment, ideally by EDTA, to assess the patient's glomerular filtration rate. There is no consensus about which dose is which dosing regime or dosing reductions are optimal for patients in their in whichever renal functional dysfunction, assessing assessing appropriate dose for a patient with a specific renal function. So we would recommend that you check with the protocol, because it will be protocol specific. But I have lifted a protocol from one of our ALL protocols here, one of our adult ALL protocols 2014, to give you an idea of the sort of parameters which a patient would have different doses of high-dose methotrexate. Other toxicities, there is some liver toxicities. Transaminitis is quite frequently encountered. 60 to 80% of all patients have some sort of transaminitis, which should be an ALT at the Marsden, between 2 to 20 times the upper limit of normal. It's often self-limiting and usually resolves within the first 2 weeks. There are some rarely encountered reports of fibrosis and liver cirrhosis. Rarely do we encounter bilirubin increase, so it's unusual to encounter a bilirubin increase. It's all about the transaminases. This is a highly emetogenic regime, so both nausea and vomiting are encountered, and stomatitis. So the mucositis associated with methotrexate is quite common. This can result in, all of these three can result in volume depletion, which we need to keep an eye on, because this will further increase elimination time. It is a very myelosuppressive regime, so you will experience patients to be neutropenic and pancytopenic. There is some good evidence to suggest that high-dose methotrexate does cause pulmonary toxicity, and within that, unfortunately, even with appropriate supportive care, phenolic acid rescue doesn't mitigate the pulmonary fibrosis. Neurotoxicity is also commonly encountered. usually within the first 24 hours of therapy. It's going to, and those symptoms include somnolence, confusion, sometimes even seizures. But they are often self-limiting, and within 24 hours of completion of the regime, patients are often, or those symptoms have certainly stopped. More frequently than I was aware of, there is a non-specific drug rash. About 15% of all patients encounter a drug rash of some description. So the next thing I wanted to talk about was high-dose methotrexate supportive care. And one of the critical aspects of supportive care is phenolic acid rescue. Without phenolic acid rescue and all of the components of salvage or rescue, high-dose methotrexate would deliver a lethal dose of methotrexate to our patients. So it's mandatory that we follow the guidelines set out in the protocol for anyone receiving high-dose methotrexate. This is a high-risk regime, and we need to ensure that we are following the protocol. So methotrexate rescue or phenolic acid rescue involves the administration of reduced folates, essentially. In the US, which have named this much less confusingly than the UK, named their phenolic acid rescue leucovorin, and in the UK it's phenolic acid as calcium folinate. This starts often on day 2, although that does vary from protocol to protocol, which I'll talk about in the next slide. This acts interestingly by an unknown mechanism of action. It's likely that the phenolic acid or the reduced pholates are utilized by non-malignant cells. It looks as though the malignant cells, or the cells which are indicated for or are treated with high-dose methotrexate, have lost the influx pumps, so they cannot utilize the reduced folates, so are uniquely vulnerable to the effects of high-dose methotrexate, which actually goes some way to also describe the mechanism of action within these particular vulnerable cells. Of note, phenolic acid is a reduced folate itself, and it's a 5,4-mole derivative of tetrahydrophenolic acid, which is a reduced folate. And going back to our slide, you can see where leucovorin, which is a much more sensible name to call phenolic acid, it interferes, or it sort of rescues the phenolic acid cycle. Now, unfortunately, because high-dose methotrexate has been a component of many different treatment regimes, many different clinical trials used in different countries, there is variation on how we deliver methotrexate and how we deliver the supportive therapy. So a question I often get asked is, when do we start the phenolic acid rescue? And really the answer is, it depends on the protocol. So we just follow the protocol. Each protocol will have its, each protocol which involves or incorporates high-dose methotrexate will have its own guidelines. A little bit like how there's protocol variations within how we, or which dose we use of methotrexate for patients with renal dysfunction. The phenolic acid recommendations or guidelines do vary. So in our Codox M and our pediatric, our adult ALL protocol, the methotrexate starts 36 hours after the start of methotrexate infusion. In our pediatric regime, it starts at 42 hours. And in osteosarcoma and the matrix protocol, it starts 24 hours after the regime. So really the answer there is just follow the protocol. Okay, I've got here an example of high-dose methotrexate regime. This is lifted from UCAL 2014. Other high-dose methotrexate regimes are available. On this regime, the phenolic acid rescue starts at 36 hours, so 24 plus 12, I'm reliably informed, is 36. The phenolic acid rescue starts here and needs to be prescribed on the electronic system, which are e-chemo system. The hardwired into the protocol are hyperhydration and urine alkalization. We hope that patients will have excreted their, most patients will have excreted their high-dose methotrexate, usually about 72 hours. But there are inpatient prescribing guidelines here for patients who haven't excreted at these hours when we are assessing their post-methotrexate levels. I've also got a little note right at the bottom that says, Chris, don't forget to remind everyone to prescribe furosemide. So we want to ensure that patients have adequate urinary output of over 100 ml per hour. If they are not, if a patient is, we're struggling to get to that level of urine output, we do recommend that we prescribe 20 to 40 milligrams of furosemide IV. And one last thing I wanted to say was the high-dose, the definition of complete elimination varies from protocol to protocol. I tend to advise that a patient's only really eliminated their methotrexate when that methotrexate level is at 0.05 millimole per litre. Okay, I think the next thing I wanted to talk about was hyperhydration, and this starts prior to the methotrexate infusion. In pediatrics, the prescribing guidelines recommend 100 to 200 millimole per meter squared, and in adults we give a flat dose of 2 litres. And hydration continues until elimination. Again, we're just trying to prevent those crystals crystallizing in the lumens, so we're essentially just flushing them out. And strict monitoring for intake, input and intake is mandatory. So again, we will need to make sure that patient's output is measured, and an early drop in output is a really bad indicator for patients who are likely to encounter encountering toxicity and delayed elimination, often in combination with an increased raise in creatinine. Okay, so the next critical thing I wanted to talk about was urine alkalization. Methotrexate is insoluble at lower pHs. Because it's a weak acid, it ionizes into its nice ionized form in more basic conditions, but in more acidic conditions, i.e. of a lower pH, it acts more like a crystal, like a salt. So it crystallizes out of solution, and that's when we get a lot of our toxicities. Toxicities for renal toxicity, but also, of course, that means a build-up in methotrexate itself, and then also other toxicities, including myelosuppression. Increasing the urinary pH from 6 to 7 vastly increases the solubility of methotrexate in its ionized form by about 5 to 8 fold. Urinary pH greater than 7 is mandatory before achieving a urinary pH of greater than 7 is mandatory before we start methotrexate treatment. To achieve this, we use sodium bicarbonate. We use relatively low doses. In the milestone, we use 50 millimole, but we often achieve urinary pH greater than 7. For patients who we struggle to get urinary pH over 7, we do have the option of giving 100 to 200 millimole of sodium bicarb. Again, another mandatory session of my presentation is that strict monitoring of urinary pH really is mandatory. And there we go, just to prove that I am a pharmacist and I do love a couple of molecules. There's the two images of the crystalline form of methotrexate and its ionized acidic form. For patients who, for whatever reason, have a contraindication for sodium bicarbonate, acetazolamide is available, and the dose recommendations are 200 to 500 milligrams QDS. So the other thing that I wanted to say about urinary alkalization is and phenolic acid rescue. Phenolic acid rescue essentially stops many of the actions of methotrexate. However, it doesn't do anything to facilitate the excretion or elimination of methotrexate. Urinary alkalization and hyperhydration are the only ways in which we're actually going to achieve adequate excretion of methotrexate. Okay, and that brings us nicely on to the nice pharmacokinetics section. After I'll just briefly run through the kinetics of methotrexate and sort of pick out the interesting points. After IV administration, methotrexate is widely distributed throughout the body. Interestingly, methotrexate is one of those drugs which is albumin bound. There is a correlation between low albumin levels and patients experiencing more toxicity. The theory goes that if your albumin levels are quite low, you're probably going to have more free non-bound methotrexate. However, replacing albumin for patients who are experiencing toxicities or delayed excretion, there's no evidence that improves outcome at all. But I often recommend to the doctors is if you've got a patient who's on a borderline for receiving a dose reduction prior to having high dose methotrexate, I'll often use patient's albumin level as a sort of final deal breaker whether a patient should have a lower dose or a higher dose. But a low albumin level in itself isn't a contraindication to having full dose, high dose methotrexate. Peak serum concentrations for methotrexate, doses greater than 1 gram per meter square, are in the range of 500 to 150 micromole per mil, and these are critical to achieving that polyglutamation within intracellular polyglutamation. The overall half-life following IV administration is between 8 and 12 hours, depending on obviously patient factors. It penetrates poorly. Methotrexate penetrates poorly through across cellular barriers. For example, vascular endothelium. So this is a problem when patients are third spacing. So the methotrexate, which has third spaced into ascites and plurifusions, may result in a slow, gradual, slower overall excretion time, because the reabsorption back into the plasma from the third spaces means that a patient has prolonged exposure to methotrexate and therefore increasing excretion time. Therefore, it's mandatory that ascites are managed, plurifusions are drained prior to high dose methotrexate treatment. This also illustrates some of the problems we have with interpreting therapeutic drug level of methotrexate, in that plasma levels are a good marker of patients who are taking a long time to excrete or are likely to encounter toxicity, but they have to be taken in a holistic context, in that we know that methotrexate goes into other organs, including the kidneys, which wouldn't be seen in a plasma level. So I also recommend that, as well as strict monitoring of therapeutic drug levels, we monitor obviously the creatinine clearance and ensure that the patient's workup has been achieved, i.e. draining ascites and pleural effusions, monitoring renal function prior to therapy and hyperhydration. So I just wanted to talk about therapeutic drug monitoring, and this is a nomograph. I think this is lifted from some of the very early trials of monitoring methotrexate excretion using TDM, but it illustrates that patients who are in the higher risk area and higher risk of encountering severe toxicities. This does correlate with higher methotrexate levels post infusion, and this is why we take levels usually starting 24 hours after the infusion has started, to ensure that patients are excreting their methotrexate. Although methotrexate, as I did say in the previous slide, does concentrate in other organs, plasma levels are still do correlate very well with patients who are going to encounter severe toxicity, and also would be a red flag for more additional supportive therapies, which I'll talk about in the next couple of slides. And it really is about how we manage these patients who are taking prolonged time, or we're not able to excrete the methotrexate from them in this period here, and often how we pick up the early warning signs for those patients, and what do we do if hyperhydration, despite achieving adequate urinary pH and phenolic acid rescue, what do we do with this group of patients? Fortunately, there is an agent known as glucarpidase. Glucarpidase is a synthetic enzyme which converts methotrexate into a glutamate and a 2,4-diamino N-methylpyruvic acid, probably said that incorrectly, which is inactive and critically metabolized by the liver. And this really is the kind of go nuclear option. It's a very high cost drug. I think the last couple of times we've ordered it, we've been charged around in the order of about £80,000. Essentially, any centre in the UK administering high-dose methotrexate has to be within a couple of hours of glucarpidase, some sort of warehouse which stores glucarpidase. And essentially, this is a non-oncological emergency where we would obtain glucarpidase any in and out of hours. The doses recommended are 50 units per kilogram, and that's been shown to reduce plasma concentrations of methotrexate by about 98%. We recommend that we stop the phenolic acid rescue, partly because mainly because the glucarpidase was metabolized up, but then restart it usually 2 to 4 hours after glucarpidase administration. And just to prove I am a pharmacist and love molecules, I've got a picture of methotrexate being metabolized by glucarpidase to diamino-methylbutyric acid and a glutamate. There we go. So how do we choose which patients monitor for which patients may require treatment with glucarpidase? And this is lifted from I believe this is lifted from one of our pediatric protocols, and it sort of goes through early identification of patients who are likely to have a prolonged excretion time. And they take a creatinine level at 24 hours, and they also take a methotrexate level. If that methotrexate level is over 150, that's a warning sign, and they take another level of both creatinine and methotrexate at 36 hours. If those levels are great, if the creatinine clearance is elevated from baseline, and if the methotrexate is greater than the methotrexate level is greater than 3, they would consider glucarpidase treatment even at 36 hours. And then this sort of follow any patients who are sort of outside that regime, outside of these parameters here, they would consider glucarpidase. And as the pediatric team have the greatest experience of the use of high-dose methotrexate and glucarpidase for that matter, I would follow their recommendations. Now, unfortunately, there is a slight disparity in the way that this high-cost drug is funded between the pediatric leukemia patients and the adult patients who are receiving high-dose methotrexate for lymphoma. However, I will say, and this is probably a little bit unofficial, that we've never failed to obtain funding for a patient who we believe would benefit from glucarpidase treatment. And I've always recommended that it's a clinical decision, and the clinical decision really should be led by the guidance that are set down in the pediatric regimes. But there are other conflicting guidelines, which I seem to have found when from writing this presentation, everything seems to conflict with everything else. There are some other guidelines which are set down by different commissioning bodies. This is the guidelines set out in Up to Date, if you're interested. These have more of an adult focus, but I think these are just used to inform clinicians where when a patient really we should be considering glucarpidase treatment. So I think the take-home message, particularly glucarpidase, is that if you have a patient who his urinary output is decreased, and or creatinine has raised, and or is taking a prolonged time to excrete their methotrexate, contact your pharmacist, contact the consultant. It can be a very early barometer of patients who are going to experience some very nasty toxicities from this relatively toxic regime. So please contact anyone from the pharmacy team if you're needing pharmacy advice regarding obtaining glucarpidase or its appropriate use. The last couple of things I wanted to talk about the pharmacokinetics of high-dose methotrexate were a couple of patient factors. Patients who are obese. We don't generally do dose reductions. The ASCO guidelines defines high-dose methotrexate as a curative regime and does not recommend a dose reduction. Patients with Down syndrome, the trisomy 21 cells appear to have an increased cellular accumulation of methotrexate because of the presence of extra copies of reduced folate carrier SLC19A1, which is located on chromosome 21, meaning that patients essentially may experience additional toxicities. But interestingly, we've got some very good data from our ALL patients, patients with Down syndrome receiving ALL treatment, and they do very well. The other thing I want to talk about, because I'm a pharmacist and I love drugs, high-dose methotrexate and various drug interactions. High-dose methotrexate is a relatively antisocial drug and doesn't tend to get on with many other drugs, and so but these are drugs often commonly used in primary care or as a part of standard standard supportive therapy for many of our chemotherapy regimes. Drugs including Septrin, cotrimoxazole, the trimethoprim within the cotrimoxazole is a dihydrofolate reductase inhibitor in its own right. And so essentially we've got two agents which are competing for the same enzyme, although trimethoprim really should be more tailored toward bacterial dihydrofolate reductase. There is also evidence that Septrin itself, outside of the dihydrofolate reductase inhibiting characteristic, does push methotrexate into other organs and therefore delaying excretion. And personally, the worst case of methotrexate-induced mucositis I've ever seen was with a patient who was still taking their cotrimoxazole before we started the high-dose methotrexate, and I've always seen that as a contraindication myself. Because it's got quite a long half-life, I would recommend a 5-day washout period to ensure complete excretion prior to starting high-dose methotrexate treatment. Penicillins, including tazocin, these are all salts of weak acids and therefore complete for the same areas in the kidney for excretion, and they will delay the excretion of methotrexate. Each penicillin will probably have a different half-life, so just check with pharmacy to see when's the earliest time we can get away with giving high-dose methotrexate. Some penicillins have quite a short half-life, some of them have more of a prolonged half-life. We normally say about 5 half-lives before a patient can have high-dose methotrexate, and I would say that's a significant interaction. And I have personally seen some patients with some very nasty cases of mucositis when penicillins and high-dose methotrexate have been co-prescribed. NSAIDs are usually avoided in hemato-oncology as a rule. We do have some patients who've continued on, unbeknownst to us, with their NSAID, and these are also particularly nasty drugs in terms of the toxicities we experience when they're co-prescribed or co-administered, shall I say. These are salt-sulfuric acids themselves, but they also significantly reduce renal perfusion, and therefore delay excretion of methotrexate, and that I would say was a contraindication. Again, if you have any patients who are still on an NSAID, any NSAID, with the exception of low-dose aspirin, please contact pharmacy. Proton pump inhibitors. There is a little paper that says there is a paper that says stating a little bit of evidence that omeprazole increases the excretion time of high-dose methotrexate. There's also a paper that's saying that it has no effect at all. And there's no evidence to say that lansoprazole increases or decreases the excretion time of methotrexate. However, because it's such a toxic regime, we do recommend that we consider stopping lansoprazole prior to treatment with high-dose methotrexate. But this would be more of a consideration of patient factors. Patients who are at high risk of some sort of GI bleed, I would have no issue about patients continuing on with their lansoprazole. We do currently we're experiencing problems sourcing alternative agents which are not proton pump inhibitors. Things like H2 antagonists, but they are a suitable option if you're particularly concerned for one of your patients. And that's the end of the lecture. I hope that's of use to you all. If you have any problems, any issues, please contact pharmacy. I left some references within the bottom of my presentation if you want to read into any of these things further. And thank you very much for listening to me drone on. Thank you. Goodbye.